Good morning, everyone. Welcome to IMO. I hope you enjoyed your stay in Barcelona and in our institution. I would like to share this clinical case with all of you. This is a 42-year-old male who came to our clinic complaining on visual acuity decline in both eyes. Past medical history reveals severe psoriasis, who's been treated with long-term steroids, methotrexate, and then he switched to efalizumab and etanercept. At presentation, best correct visual acuity was 2100 in the right eye and 2200 in the left eye, and he had a mild hyperopia. And this is the clinical features of we found on fundoscopy. What is interesting is those small, pale or punctate subretinal deposits in the macular area and some RPE disturbance. Same findings in the left eye, those pale, teeny subretinal deposits on the macular area, some RPE disturbance. And on wide field retinography, we can see that the RPE disturbance moves towards the mid-periphery. This is more evident on autofluorescence imaging, where we can find some areas of RPE atrophy, some diffuse hyperautofluorescence on the posterior pole, and those small clumps of pseudovitelliform deposits underneath the retina at the margin of the lesion. Those findings are also revealed in the left eye. You can see those small clumps of vitelliform deposits underneath the retina. On OCT scan, we can find some subretinal fluid, the deposit I have already mentioned, and some intraretinal cyst in the retina. This is the right eye, and in the left eye, those features are more evident. So we perform electrophysiologic testing, and full-field ERGs were reduced and delayed for both cone and rod responses. And on electrocoolography, the ardent ratio was abnormal with 1.1 on the right eye, 1.0 on the left eye. So the diagnosis can be challenging. We can think maybe this is a chronic central venous retinopathy induced by steroids. Maybe we can think in inflammatory autoimmune retinopathy or inherited retinal dystrophy. We thought that this was more compatible with inherited retinal dystrophy. We performed gene testing and we found a novel homozygous mutation for BES1 gene. So the diagnosis is autosomic recessive spastronopathy, which is a clinical entity that has been described in 2008. As you know, mutation in BES1 gene can produce a broad spectrum of ocular phenotypes, like the most common is BES vitelliform macular dystrophy, also adult onset for macular vitelliform dystrophy, which is a pattern dystrophy of the RPE, also autosomical dominant vitreoretinal choroidopathy, and autosomical dominant microcornea round cotton dystrophy, early onset cataract, and posterior staphyloma. And in our cases, the autosomal recessive bestrophinopathy. As I mentioned before, this case was first described by Rosemary Burgess in 2008, and the main features are loss of central vision in early in life, hyperopia and risk of angle closure glaucoma, irregular RPE alteration with whitish subretinal deposit on the macular area, subretinal and intraretinal fluid accumulation on OCT scans, the lack of dominant mode of inheritance, and abnormal electrophysiology. This is the case that was described by Rosemary Burgess. You can see the same features, the small clumps of vitelliform at the margin of the lesion, some subretinal fluid. We can also find it on Best disease, but what is not common in Best disease are the intraretinal cysts that we can see at the OCT scan. So this is the case. We studied two cases from two families. We published it in Investigative Visual Science. This is the case that I already presented you. with the features. What is interesting in this case that we look at the sister of the patient who was heterozygous for the mutation, and she has a normal phenotype, also in electrocoolography. This is the second case, who is a 17-year-old male with a best correct visual acuity of 2100 on the right eye and 2040 on the left eye. And in this case, we also can see the pale, opaque punctate deposit on the subretinal deposit on the macular area, and some vitaliform deposits also in the macula on both eyes. On OCT scan, we can find the same features: the subretinal fluid, intraretinal cyst, and in this case, we can see the vitaliform deposit underneath the retina. On the autofluorescence imaging, we can see the vitaliform deposition and also the same aspect that we saw on the other patient. We recently diagnosed a new patient with this disease. This patient was previously diagnosed of Best disease complicated with Irving-Gass syndrome because he had cataract surgery on both eyes due to a shallow anterior chamber. And this is the aspect, the small punctate deposit, which is a common feature in this disease. The OCT is very common also in this disease with subretinal fluid and intraretinal cyst. And in autofluorescence, we can see the RP alteration, some clumps of vitaliform on the periphery, and also optic distribution that has not been described in this disease until now. What is interesting in this disease is that we have a biallelic functionally null mutation who lead to an early transcript degradation or non-functional proteins, and this represents the null bestrophin-1 phenotype in human. As you know, BEST1 gene encodes the bestrophin-1 protein. We perform real-time PCR analysis of the messenger RNA, and we can find in our two first cases that the percentage of BEST1 transcript was very low on our two cases, but in the sister, who was heterozygous for the mutation, we have a 60% of bestrophin, although the phenotype was normal. This is in contrast what we found in dominant bestrophinopathies like Best vitiliform macular dystrophy, that those mutations do not compromise the protein synthesis. We have 50% of normal protein and 50% of abnormal protein, and it's the 50% of abnormal protein who produces the phenotype. Those mutations are gain-of-function mutations that exert a dominant negative effect on the wild-type allele. So in conclusion, the spectrum of BEST1 phenotype is extremely varied. ARB is a specific and recognizable phenotype, and gene testing and molecular analysis will shed light on the emerging genotype-phenotype correlation in the future. So thank you very much for your attention. I would like to acknowledge the retina department and especially the genetic department who work hard on the work of this topic. Thank you very much, and I hope you enjoy your stay in Barcelona.